All right, it is so great to see everyone. Good evening. Welcome to UT Southwestern Science Cafe. We are so glad you have joined us tonight. My name is Jenny King, and I'm Director of Public Affairs at UT Southwestern. And on behalf of my colleagues, Mindy Sass, Charlandra Thompson, and our guest speaker, Dr. Andy Sizz, thank you for joining us tonight. As you may recall, Science Cafes are informative, fun, interactive conversations where our speakers take you on deep dives into science. We encourage you to ask questions and engage with us during this program. This evening, we'll be discussing mental health, advancements in treatments and technology with Dr. Sizz. Today's topic is an interesting take on how technology is impacting clinical treatments, similar to the tech focus of our most recent two Science Cafe presentations on HIFU and Pulsar. We will discuss this intersection between patient care and technology. Before we begin, we have just a few technical matters to review, so here we go. We are recording this program as well as live streaming tonight's event on our UT Southwestern Twitter page. Please go ahead and mute your microphones to help with audio clarity for everyone, and unmute yourself if your name is called so you can ask your question. And we do encourage you to utilize the chat feature to list questions for Dr. Sizz. We will call on audience members to ask their questions following his presentation. Mindy will be facilitating Q&A, and Charlandra and I are working behind the scenes to monitor your questions. And finally, just a reminder, while we cannot answer personal medical questions, we can and welcome your general questions. And with that, I am very pleased to introduce our presenter. Dr. Andrew Sizz is an assistant professor in the Department of Psychiatry at UT Southwestern, and he is what I affectionately call a double doctor. He earned both his medical degree and a doctoral degree in neuroscience at the University of Illinois at Chicago, followed by a research track residency in psychiatry here at UT Southwestern. He is certified by the American Board of Psychiatry and Neurology, and he joined our faculty in 2019. Dr. Sizz has published numerous academic articles and is involved with several clinical trials and other research projects related to depression at the UT Southwestern Center for Depression Research and Clinical Care. His work includes understanding novel treatments for depression, such as esketamine and rTMS. He also studies the use of biomarkers to better understand the biology of depression in order to help match patients with the best treatment. Dr. Sizz's clinical focus areas include treatment-resistant depression and interventional psychiatry. In 2019, he earned a new investigator award from the American Society of Clinical Psychopharmacology. Welcome, Dr. Sizz. The virtual podium is yours.
Thank you so much, Jenny, and thank you all for joining me tonight. I have to say, one of the most exciting things about my job is getting to share and speak about my work in mental health and the field in general. Before we dive into the meat of today's talk, I want to mention a few disclosures and thank yous. One thing that all of you should be aware, I'll be talking about intranasal esketamine, and I helped work on the phase 3 clinical trials for that, which may be a slight conflict of interest, although I do receive no royalties or anything like that moving forward. I'm also going to present to you some data that's been funded by numerous sources, including the National Institute of Mental Health, National Institute of Drug Abuse, and generous support from several foundations. But more so than any of that, I just want to say thank you from the beginning for all of our research participants, or as I prefer, partners, who have made the type of discoveries I'm going to be talking about today possible. Thank you all. And before I talk about advancements, I just want to talk briefly about where we're at as a field in mental health today. I know the impact of 2020, including and especially including the COVID-19 pandemic, has been on a lot of people's mind and how that's affected mental health care and mental health symptoms. It's a great question. I think we're learning more and more every day, and there's a lot of reason to be concerned that this past year is going to have a huge toll yesterday, today, and tomorrow on people's mental health. But what I'd also like to say is that even prior to 2020, we weren't in a great place. The prevalence of mental health disorders was high and worsening even prior to the pandemic and the other events of 2020. 1 in 5 adults suffer from some type of mood or anxiety disorder, disproportionately affecting women in a ratio of 2 to 1 compared to men, as well as disproportionately affecting racial, ethnic, sexual, and socioeconomic minorities. And while these disorders have tremendous impact on quality of life, as well as work and productivity, of course, the most serious outcome of these disorders can be suicide. To take it local here in Texas, suicide is the 11th leading cause of death overall. And in our youth aged 15 to 34, it's number 2. So while there's a lot of reasons to be pessimistic or down about the state of mental health, I want to take today to talk about some exciting things on the horizon and reason for excitement. And specifically, I'm going to focus on advancements in treatments and advancements in technology. I want to give you some examples of how we've made strides in the treatment of treatment-resistant disorders, as well as advances in substance use treatment, as well as talk about technology in the context of clinical care and how advancements in technology are impacting discovery and research. To get started, to talk about treatments, I've got a question for the audience, and I believe you all will have a poll come up. And just to kind of get started, how many medications are available for major depressive disorder, unipolar depression? This is something we have a lot of, not very many. What do you all think? I'll give you a few minutes to respond.
We're almost there at 100% participation. Thank you, everyone. Almost there, almost there. Finish your voting. I'm going to close it out. 3, 2, 1.
Great. So we got a pretty even split, huh? Majority chose more than 25, but a nice distribution across all of these, which I think means it was a good question. The answer is 28. So E would be the correct answer. We have 28 different medications approved for major depressive disorder, and that's just counting those in the United States. We have several others in Europe and abroad. And then we also have other medications approved for bipolar disorder and other medications used off-label in major depressive disorder. And in fact, this is one of the single diagnoses in all of medicine where we have the most different medications approved, yet we're still not adequately treating depression. I think we have so many because it's just such a prevalent disorder. So even if you're the 5th most popular antidepressant on the market, there's so many people suffering from depression that you still have a good market share. But I also think there's a lot because people keep trying to make a better one. And unfortunately, for the most part, we've not succeeded in this. Pretty much all of these medications have been shown to be relatively equal on average. Some people definitely benefit more with one versus the other, but on average, they're pretty much equally effective. And of course, that's 28 medications. We have a lot of different treatment options for mental illness, and that's depression or otherwise. I generally put these into 4 different buckets: psychotherapy, medications, something called neuromodulation, and then of course a catch-all other bucket that includes things like exercise and maybe even diets or supplements. Some of these have evidence for treating mental health disorders. All of these may be important pieces of the puzzle for certain disorders and certain patients, and often we use these in combination. Today, though, I'm going to touch specifically on advancements in medication and something called neuromodulation. And I'm going to start by talking about what we sometimes refer to as treatment-resistant disorders, or the term I prefer is difficult to treat disorders, mostly because if it's treatment-resistant, why bother trying? Typically, this is defined as someone who has significant symptoms even after trying 2 or more evidence-based strategies, whether that be medications, psychotherapy, more medications. And in most disorders, this is typically about 1 in 3 patients. Certainly the case in major depressive disorder, about 33% of people would meet this criteria. And for a long time, we haven't done a lot of research in this area. We keep coming out with new medications, but very little focus on those who have already tried them. What should they try now? Are there specific medications for this population? For a while, we've had one good treatment, which is electroconvulsive therapy, which is absolutely life-saving and wonderful for some patients, but it's not for everyone. It has significant side effects for some patients. And so what we've been doing for the most part is just try the 3rd, the 4th, the 5th, the 28th medication, and very little options for people specifically with difficult to treat symptoms. In the past 10, 12 years, that's changed. And there's 2 exciting treatments that have come out: transcranial magnetic stimulation and esketamine. And these treatments may be effective in some patients with difficult to treat depression. TMS is a form of neuromodulation where we directly stimulate the brain. Sounds kind of scary, but in the case of TMS, it really isn't. We apply a very mild magnetic field, typically the size of a nickel, to certain areas of the brain. In the case of depression, we target this area right here, the left dorsal lateral prefrontal cortex. And I want you all to remember that if you can, because we'll be talking about it again in a little bit. This magnetic stimulation seems to activate that area of the brain. It's non-invasive. Patients are awake for it. All you really feel is a mild tapping sensation, and actually has probably less side effects than most medications. So really cool stuff. Esketamine is another medication, but it's a very different one. One way it's different is it acts on a different neurotransmitter than all of our other antidepressants, the neurotransmitter glutamate. It's also different in how it's administered. For one, it's either a nasal spray or, in the case of ketamine, an IV. So that's different, but it's also not taken every day. It's usually given 2 to 3 times per week, and the effect of the drug really only lasts in your system for an hour or 2. Yet the long-term effects on mental health seem to last for days, weeks, maybe even longer. So a very different way to deliver a medication. It also appears to be fast-acting in some patients and may be particularly helpful at treating symptoms related to suicidal thoughts or behaviors. In both of these cases, they're new treatments that act in new ways that help people who have not benefited a lot from other treatments. That's very exciting and desperately needed in our field. Unfortunately, these treatments aren't going to work for everybody, and they certainly aren't lifetime cures for depression, even if they can dramatically reduce symptoms in the short term. But more than just offering that relief to patients, what I think is so exciting about these new avenues is that it's given us hope and new directions to look for in research. Things like TMS work. Ketamine can work for some patients. And it's opened up a whole new avenue. In the case of TMS, there's a lot of ways we can modify this treatment and try it out on different areas of the brain with different stimulation patterns, not just for depression, but almost any brain disease, including ones outside of psychiatry. And in the case of esketamine, has really revitalized the field of so-called psychedelic psychiatry, using powerful drugs in short periods of time, maybe once, twice, or a few times, where patients have profound but relatively fast experiences, and has led to a lot of interest in other psychedelic compounds such as psilocybin, MDMA. Both of those have had recent, very promising, but still early results in clinical trials, and we may see those hitting clinical care in the next few years. To switch gears a little bit, I want to talk about treatment for addictions. And so I have another question for you. This one's a true or false. And the question is, true or false? Effective medications are available to treat most substance use disorders or addictions. What do y'all think? I think the poll is popping up. I think Do we still have the old question?
Sorry about the polls. Just put your answers in the chat if you don't mind. The poll is not working for me unless we want to go back to the first one.
All right. So I'll go ahead and skip to the answer.
Thank you.
So in this case, the answer is false. Fortunately, we do have several medication options for certain substance use disorders, nicotine, alcohol, and opioid use disorders, and the last two being particularly deadly ones. That's great. But in contrast to depression, we only have about 2 or 3 medications for each of these. And on top of that, there are several really important substance use disorders that have no evidence-based treatment options. That includes stimulants like cocaine and methamphetamine and cannabis use. And particularly in the case of stimulants, this is worrying given the rise of stimulant addiction over the past 10 years. Millions of Americans use amphetamines in a given year. And while they're much less likely to be lethal and overdose compared to alcohol or opioids, when patients co-use stimulant and opioids, the risk of overdose is much higher than if they were just using opioids alone. So it's a growing concern that we don't have a great answer to. That is until very recently. So one of the most exciting things I think to come out of our department this past year, some of you may have seen, was the first ever positive large treatment study using a medication for methamphetamine use disorder. The study was called ADAPT-2. The results were just published in the New England Journal of Medicine. And what you'll see here is compared to placebo, where only about 3% of patients had any significant reduction in their methamphetamine use, people who received this combination of repurposed drugs, about 11 to maybe 16% of people had a significant reduction. So way better than placebo. However, I will admit, not where we want to be. It's 15% a great result? No. But what I will say, just like with TMS and esketamine, this isn't the grand solution to all, but instead what it does is instill this hope that advancements in treatment of substance use disorders is possible. And these exciting results have already spurred us to start development on the next studies. We have 3 really exciting studies in substance use disorder queued up for this fall, including one that's using that technology TMS that I mentioned. And we'll circle back to that at the end of today's talk. So we talked a little bit about advancements in treatment, and I'll tie that in again at the end. But now I want to transition and talk a little bit about technology. And I want to talk about that in 2 contexts. First, the context of how technology impacts how patients, how clinics, doctors, and researchers connect with patients. And then I want to talk about technology in the context of advancing how we measure and understand brain function. So to get real simple, connecting with patients, how has this historically worked? Patients live at home, they visit a doctor's office. Depending on their doctor's office, they may or may not talk about their mental health. Sometimes there's no time, sometimes the doctors don't feel comfortable, sometimes the patients don't feel comfortable. And even if they do talk about it, standardly they'll follow up in 1 to 3 months maybe. Over the past year, we've radically changed how we deliver care. A lot of our healthcare has shifted to telehealth, for better or for worse. And as a consequence of that transition, not just the doctors are using technology as part of care. For the first time, pretty much all patients are using technology, including my 70 and 80-year-old patients. They're sometimes learning how to use a smartphone just so that they can participate in their healthcare. And as a consequence, now that everyone is using technology, it's produced a really nice opportunity to integrate technology more and more into our clinical care. And I think this is truly just beginning. But in the context of mental health, where this may be especially important is when it comes to what we call either technology-based symptom tracking, or some of you may have heard the term before, measurement-based care. And what this is quite simple. Standardized routine assessment of mental health symptoms, typically done with a questionnaire. the frequency and intensity of a variety of symptoms you may or may not be experiencing, not just being asked once, but multiple times. And while a simple survey of your symptoms is kind of basic and not super technologically fancy, it's been really, really hard to get healthcare systems to do this and become much easier with the forced use of telehealth and technology in healthcare. And this is so critical because we know it helps. In the case of primary care, if you don't use any kind of symptom tracking or measurement-based care, remission rates of depression are about 6%. Very, very low. When you use technology, and our research group helped pioneer one version of this called Vital Sign 6, remission rates went up almost an order of magnitude in primary care settings. Almost as good, maybe in some cases better than a lot of psychiatrists treating depression. The other thing, though, that technology has allowed us to do and has become more and more common is self-monitoring of symptoms. So instead of relying on patients to be asked by their healthcare systems how they're doing, more and more patients are turning towards some form of self-monitoring of symptoms using apps or websites. Recently, the CDRC has put out our own application for this, which you can find at the centerfordepression.org website. We call it Avexia. And the idea here is patients own their data. They own how they feel, and they can track it on their schedule, on their timeline, and they can control where it goes or doesn't go. And so if they want to share this with their doctor, great. And as a physician, what I really like about this is that it means that patients can potentially track their symptoms in the same place over the course of not just days or weeks, but maybe years. So a patient who's receiving care for 5 years in Colorado moves to Texas, they control this and they can share it with me rather than me having to fumble with electronic health records that do not communicate well across states and cities and healthcare systems. The other way that connecting with patients has changed over the past year is how we do research. In the early days of the pandemic, we were not allowed to have research participants come into our clinic and see us, and we were left with the choice of either stop doing research or do it remotely. And of course, we chose to do it remotely. And this can fall into different flavors. One that's, again, kind of simple is just having online versions of things that we would normally have people fill out on pen and paper in our clinic. Another way that's still developing but is really exciting is how we can use your digital life or your digital fingerprint to better understand mental health. The consequence of using online surveys instead of coming into clinic means that instead of getting you to come see us maybe 3 times a year, we can get much higher density data. So we can send out a survey every 2 weeks or once a month and get a set of data after data after data and really get more granular or high density information about people's symptoms over time. We took advantage of this at the beginning of the pandemic because we knew that there would be some impact of this dramatic change in all of our lifestyles and people's mental health. And we were in a really exciting position to do this because not only did we have the know-how and know what kinds of questions to ask, but for years now, the CDRC has been following patients with depression longitudinally. And we had about a cohort of around 1,000 people just prior to the pandemic, some of which we've been seeing for years and years and years, and just tracking the natural course of their symptoms. So when the pandemic hit, we had an opportunity to uniquely study people that we knew very, very well prior to the pandemic. So starting in April, we started sending out surveys about twice a month about how their symptoms were doing. And we also asked questions specific to the pandemic, such as how this has changed their access to mental health care or impacted their social support. And we've got a lot of analysis going on about this, but the first one I'll share with you, which was we divided the group into 3 buckets based on how they were doing just prior to the pandemic starting in late 2019. And we divided it based on people who had really no symptoms of depression right now, even though historically they have, those who had more mild symptoms, and those who had moderate to severe symptoms. And I want to give you all the moment to be the researcher and come up with a hypothesis about what we found. I made this a poll question, but that may not work.
I'm gonna try it. Let me see if I can figure out why it's not toggling. Give me 2 seconds. I end that polling.
Well, while we're waiting, just think, what did you all expect? Did you expect that people with recent symptoms of depression were more vulnerable to mental health decline during the pandemic? So if you were depressed at the beginning of the pandemic or just before, did you have a greater decline?
We're at 66%, 72. I'm gonna give it 5 more seconds. And I'm so thankful that I figured out how to get to this third question.
Thank you, Jenny.
I know. Okay, I'm gonna end the polling and share the results.
So the majority of people thought like I did, which is that recent mental health symptoms would make you more vulnerable to decline during the pandemic. A few of you, though, were actually smarter than me, because what we saw was quite surprising. Compared to late 2019, when we looked at symptoms of depression in April 2020, regardless of whether you had no symptoms in late 2019 or a lot of symptoms in 2019, symptoms were actually pretty stable during the early pandemic. And we continue to follow these patients, and we've analyzed the data up through August. And what we've seen in all 3 of these groups is that, again, symptoms of depression have been relatively stable. And we also looked at anxiety and various metrics of quality of life. And for whatever reason, the participants or partners in our research have been surprisingly resilient. And what I'll say is that that's on average. There were definitely people who worsened, some people who actually did a little bit better. There was also variability over time. So that doesn't mean people didn't have bad weeks or months, but on average, we didn't see dramatic shifts. This is actually in contrast to a lot of other research. Some of this has been in the general population, which might be different than our cohort, which is individuals with a history of depression. And so it's possible that maybe people who have struggled with mental health at some point in their life were better equipped to handle this kind of stressor. They knew how to connect to mental health treatment. They had other coping mechanisms in mind. Maybe we're already in psychotherapy or whatever else they're doing. But still, it was surprising. And so we did dig a little bit deeper in the data to see, were there specific things that really impacted these individuals in how their symptoms progressed during the pandemic so far. And we did find 2 interesting things, specifically that disruptions in patients' ability to access mental health care and disruptions in major aspects of their life, such as becoming unemployed, or disruptions in school or childcare obligations, those things were our best predictors of some type of worsening of mental health. And actually what we saw was, if you had a disruption early in May, you still had worse symptoms months later. Surprisingly, we didn't see an effect of changes in social support. So people who had some type of disruption in social support, we didn't see any relationship between that and worsening mental health. And my best explanation for this is that that's something that people were able to work around somehow. They were able to switch to online Zoom meetings with friends and family, or reach out to them in some other way. Whereas if you lost access to your health insurance or your mental health care clinic, there was nothing to compensate. We also saw this effect in symptoms of anxiety and quality of life. We have not yet looked at the impact of COVID diagnosis in mental health, but that's one of our next steps that we're really interested in understanding. Another area that we have changed how we connect with patients is this whole digital life that we all have now. And there's a lot of exciting interest in how all the data that's collected through our smartphones could tell us about behaviors and resilience related to our mental health. So for example, our social behaviors, we know that when people are depressed, they often socially withdraw. And so could something like responding to text messages be an indication that someone's depressed or resilient? Things like physical movement from the GPS on our phone, or the step counts from our phone or our smart devices, or maybe our sleep patterns, which could be summed up simply as the amount of time we're not using our devices, since many of us are glued to it every waking hour. And so there's this interesting question that we don't have a full answer for yet, but can we use this for more than just targeted advertising? Could this be used to better understand brain health? We'll see. Last, I want to talk about the most exciting part, which is advancements in technology for understanding brain function. Currently, I would put this into 3 buckets. First, can we measure brain's output? So our behaviors, and using smartphones might be an example of measuring our behavior, how often we're texting, for example. We can measure the brain's blood flow and structure through things like MRIs, and that's how we get those beautiful pictures that many of you have seen. And then finally, we can measure the brain's electricity through something called EEG, which historically has given us a bunch of squiggly lines. I'm particularly excited about this last option because we've made some really neat advances in how we use this data. And not only that, unlike MRI, which admittedly can tell us some amazing things, EEG is cheap, fast, and there's no claustrophobia. This is me getting an EEG in our lab. I'll admit I've got a little bit of attitude in that picture, but I promise you it's pretty comfortable. And historically, all we could get from EEGs are some squiggly lines, which were only helpful if something was really wrong, such as someone having a seizure. But recently, we've kind of come up with 2 solutions to this. One is we've been able to transform this into some pretty cool pictures, kind of like an MRI does. Or 2, we could say, you know what, these squiggly lines, I'm a human, I can't understand them, but ultimately they're zeros and ones. A computer can understand those. So let's just have the computer do it. And so about a year ago, we did this. We took a bunch of EEGs from patients who were about to start treatment for their depression. We processed those images a little bit to make them a little bit more useful. And then we told the computer, an AI machine learning algorithm, can you use this data to predict this outcome, whether or not people ultimately would benefit a few weeks later from treatment? And what we saw was really impressive. The algorithm was able to predict on the y-axis here, the actual change in HAM-D, which is a measure of depression severity, quite well. If this was a perfect prediction, this line would be a 45-degree angle and all these dots would be on it. And of course, there's some dots that are not, but this is a really compelling result and something that we haven't seen a lot of in the mental health space. And to show it a slightly different way, if the algorithm predicted you would respond to the treatment, about 66% of people did. If it said you weren't going to respond to the treatment, about 20% of people did. And really impressive is that this algorithm worked for people who got the antidepressant, but in this trial, some of the people got a placebo, and some people do respond to placebo treatment, but this algorithm could not predict that at all. So highly specific to this one drug. So the next steps are to try this on other drugs, and maybe we can have an algorithm for treatment A, another algorithm for treatment B, C, D, E, maybe all 28. Run an EEG data through all of those and potentially match patients to the right treatment without as much trial and error. The other next step, though, is to better understand what this algorithm's doing, what areas of the brain it's pulling data from, and what can that tell us about depression. And we can kind of do that already. So when we do EEG, basically you put a bunch of electrodes on the scalp, and that's what these colors show. The colors change with different intensity of electricity, but what you'll notice is there's a lot of gaps between these dots. And so using some advanced math that personally I don't understand super well, but fortunately I work with a lot of smart people who do, we're able to fill in more and more of these gaps. And instead of just having a bunch of dots that blink in colors, we're starting to better fill in those spaces and get higher resolution information about brain function using something as simple as EEG. And so we can then take snapshots of these blinding colors, and we can basically use this to compare brain function in any two groups that we might want to, and produce really high quality images of brain function in our patients. Right now for research, maybe soon for clinical care. And so we've done this a little bit with that same data from our machine learning algorithm. And so again, taking treatment responders versus non-responders, how is their brain function different? So after a week of treatment and the responders, we see this flurry of increased connections to this area of the brain. In our treatment responders, we don't see that. We see some changes elsewhere, but not as pronounced and not in this area. And it was really cool to see changes in this area of the brain because it's the same area of the brain that treatment TMS directly stimulates. And so my takeaway from that is that some patients, when they receive a medication, that medication may stimulate this area of the brain, but for whatever reason, we have some responders who it doesn't stimulate. But maybe what we could do is use this algorithm for the patients that it says they're going to respond to medication. That area of the brain is probably going to change. Medication is going to be sufficient. But for those other patients, the algorithm says, I don't think a medication is going to cut it for them. We could then move on to this other treatment. So really personalized medicine. I want to close by just talking about TMS in a few other contexts. TMS is so versatile as a treatment technology, not just as a single treatment, that it really has the potential to target a lot of mental health disorders. It's recently got FDA clearance for OCD and smoking cessation. Insurance isn't covering it yet, but it is approved. And there's smaller studies showing it can be effective for things like schizophrenia. And I'm particularly excited about a study we're launching to investigate this for methamphetamine use. What we're going to be doing is giving patients for 8 weeks either active or sham TMS and see if their substance use changed. But along with that, we're also going to be collecting EEGs. And so we hope to have the largest repository of EEGs of patients addicted to methamphetamine, and then also see how that changes with this treatment. We're also going to be doing all sorts of remote monitoring throughout the study, including patients getting questionnaires via text message on their smartphones and wearing Fitbit-like devices to see how their activity levels change throughout treatment. Really exciting stuff, integrating technology with new treatments. I'll close before we start questions by summarizing that we have several new types of treatments available in the mental health space. Technology is rapidly evolving clinical care, allowing for more frequent check-ins, more flexible cares, and hopefully more ways of measuring symptoms. And there are more tools than ever to measure brain function, and I'm really excited about those that are inexpensive, easy, and rich in data. And with that, if you didn't get anything else out of my talk, I have a picture of my cute puppy. So I hope you enjoy that, and I look forward to hearing all of y'all's questions.
All right, we'll hop right in. So it looks like we had a couple questions come through. I'm going to start with Subarayudu's question. Subarayudu, if you want to unmute and go ahead and ask your question, that would be great.
And if someone doesn't feel like speaking up, I'm happy to answer them via our team.
It looks like I'm going to wait and I'll jump to Jennifer Jafari. If you want to unmute and ask your question.
Okay. Well, I was just curious because I have some friends that suffer from depression, and my sister does, as a matter of fact. And she always says she's fine, and they said they're fine. So I just wonder, when you put out these questions and take surveys, are people really honest? And the reason why I asked that is that there was a question, urology question actually, and it varied the question content just slightly. And so the doctor was actually able to figure out what was really going on versus what the patient shared with the doctor. Do you have any mechanism like that you vary the questions just slightly and it better enables you to hone in on what's really going on? Because everybody doesn't want to admit they have a mental issue.
Absolutely. That's a great question. And yeah, people have done some research in that. I think in routine care, we don't change the question too much just because it's hard enough to get doctors to use these questionnaires. We don't want to confuse them any more than we might already be doing. And I also want to clarify that, these symptom trackers are valuable tools, but they are absolutely not meant to diagnose disorders. If they were, Dr. Google would be where we get all of our, Prozac and sertraline, and I'd be out of business. And so they're meant to help facilitate the conversation. And I think one of the biggest values of them is it at least brings up the conversation at every doctor's visit if it needs to, just like a conversation about your blood pressure or your temperature is brought up at pretty much every doctor's visit. I think, there are going to absolutely be patients who are afraid to answer those questions truthfully, either because they don't want to admit it or because they don't want to have the conversation. Likewise, there are probably patients who would not have brought it up unless they could start off by doing a self-report. And ultimately, I think the evidence is in the results. And the results are that when we use these tools, we do see dramatic improvements in depressive symptoms. And so there are at least a lot of patients who are using these surveys honestly. Thanks for that question. What else y'all want to hear about?
Let's see. We have a question from Wendy about TMS. Wendy, if you want to unmute and ask your question, please do. All right. I'm going to go ahead and read some of these off. So Wendy's question was, is there any application of TMS for dementia?
Yeah, that's a really exciting avenue of research. To simply put, I think the answer is there probably will be. Unfortunately, it just hasn't been studied as much as I would like it to be. It's really interesting how psychiatry has kind of taken over TMS, and we're really the ones driving it. Whereas traditionally neurology is the one who's more invasive and fancy with their MRIs and technology, and psychiatry, we just sit back and talk. But we've really led the front in TMS, and we're excited to partner with our neurology friends to help with disorders like dementia. I don't know if TMS could potentially cure things like Alzheimer's or Parkinson's disease, but it may help with symptom reduction. People have started to use it or experiment with it for like motor problems related to Parkinson's disease, or there's been a little bit of work in Huntington's, which has a lot of motor problems associated with it. And so certainly any brain disease where stimulating or inhibiting a certain part of the brain could be helpful. TMS may have a future.
Great news. Thank you. Subara Yudu, I believe you joined us via the phone. So I'm going to go ahead and give you one more shot to unmute and ask your question. Let's see.
And if not, ask it for him if you don't mind.
Okay. Early on in the presentation, they had asked, while it is good to hear about the treatments, it would be helpful to understand the reason for the significant numbers. So when you were talking about the numbers early in the presentation, is it related to diet, pollution, chemicals in the food supply, all of the above, or do you think it might be related to something else?
So is the question related to the rise in mental health disorders?
Yeah.
Yeah, boy. That's a great question and a really hard one to answer. I think in part because we don't really even understand what causes mental health disorders to begin with. We're really starting to understand this is what's maybe different in some people with depression or addiction or psychosis. But to even come up with the cause of why there are those differences, it's maybe correlative at this point. So these things have also happened at the same time that mental health disorder incidence has gone up, right? So yeah, in the past 10 years, rates of substance use have gone up and rates of smartphone use have also gone up. Is it smartphones causing us to use drugs? Probably not. It's the same kind of story of what happened with autism, where we really looked at the data and saw autism was on the rise at the same time of vaccines. And so it must be that vaccines are causing autism, and that's been widely refuted. So we don't have a smoking gun. A lot of it's correlative until we understand what the biology of mental illness is. It's going to be really hard to know what does cause it. Do I have some candidates? Absolutely. We know that physical health, for example, is really important in mental health. And in fact, exercise 150 minutes per week can help a lot of people with depression, in some cases as effective as fluoxetine or psychotherapy. And we've had a dramatic reduction in the amount of physical activity that we get. So that could play a role. We know that certain parts of our diet may play a role. For example, they've looked at epidemiologic studies that places where there's a high fish diet have lower rates of depression. And so that led people to investigate whether fish oil or omega-3 fatty acids could be effective treatments for depression, something that most Americans do not eat very much of. And sure enough, for some people with depression, supplementing with those fatty acids can really help their symptoms. So long way of saying, absolutely, it's multifactorial. It's going to be hard to know the answer until we better understand what are these diseases.
Thank you. We have a question from Catherine. Catherine, do you want to unmute and ask your question?
Yes, I can do that. Can you hear me?
Yeah.
Hi, Catherine.
So there's a lot of overlap, I know, between anxiety disorders and depression. So I was wondering what kind of overlap there is between the effectiveness of different kinds of treatment for different anxiety disorders and depression.
Yeah, that's a great question and a really important one. I feel we really do anxiety a disservice sometimes in that I'm guilty of this too. You just lump it in there, depression and anxiety, as if it's this same thing, or if it's just kind of the secondary thought, when we know there's a huge burden of anxiety. And for some people, it does go along with depression very intimately, experience both kind of at the same time. But for a lot of people, it's a very separate thing. And for whatever reason, as a field, we've done a bad job of studying anxiety. I think part of this is because we had really powerful drugs that can acutely treat anxiety, things like Xanax or Klonopin. I give you some Xanax, your anxiety will be better for an hour or two. And as a field, we decided that's good enough, even though it's not. And they're typically not good long-term solutions for treating people's anxiety. And we've really neglected the specific treatment of anxiety, at least from a medication standpoint, far too much. Most of the antidepressants, even though they're called antidepressants, can help some people with anxiety, but not all individuals. And long way of saying we need to pay more attention to anxiety in our field, both in terms of developing new treatments and better understanding the biology. How is it related to depression? How is it different? What areas of the brain or connections in the brain are relevant to anxiety and what are relevant to depression? And there's been a little bit of work in the TMS field where people have started to target areas specifically for anxiety, but it is kind of the neglected stepdaughter of depression, and we need to do more work there.
Thank you. We have a question from Kristen. Kristen, if you want to unmute and ask your question, please go ahead. Give them a second.
She doesn't have her mic today, she says. Do you want to
Okay,
unmute her?
I can do that. Yeah. How do the, I might butcher this, by the way. So how do the short-term effects of esketamine on glutamate differ from long-term treatment with something like lamotrigine? I don't know.
Oh,
if
wow.
you're right.
Yeah, that's a great question. So lamotrigine is the other medication that we know affects glutamate signaling directly and is used in some patients with depression. It's got a lot more evidence in bipolar depression, but also used a little bit in unipolar depression, and also affects glutamate, we think, in a very different way. Often you'll hear doctors like me talk about glutamate and serotonin as if it's just kind of one thing. And there is one molecule that is glutamate, but there's probably about 8 to 10 different glutamate receptors. And beyond the receptors that glutamate binds to have neurons talk to each other, glutamate can bind to a whole host of other proteins and so forth. So we think that ketamine and glutamate affect different glutamate receptors. And this is evident because if you take lamotrigine, you don't have any kind of unusual sensory experiences, whereas if you take ketamine, a lot of people can feel sedated or feel kind of in a different state of mind. So very, very different actions on glutamate. And this is simply because any single neurotransmitter, whether it be glutamate or serotonin, has several different receptors that they act on.
Awesome. Thank you for the question. And then I'm going to ask one that came in early, but it looks like one of our teacher friends who joins us every week also submitted it in advance. So she said she's a high school science teacher. Is there a difference in effectiveness on treatment based on patient age or gender?
Yeah, really great question. I'll tackle the age piece first. So on average, treatment is effective in young people, old people, middle-aged people, which is the good news. Probably a little bit less effective in older individuals. And we think this is related to two things. One, just the older you are, the more likely you are to have other medical problems. And for whatever reason, the more comorbid medical issues you have, the more difficult to treat depression and maybe other psychiatric disorders is. So things like diabetes, hypertension, especially things like a history of a heart attack. Depression is treatable, but more difficult to treat on average. The other issue with age, though, is that the older you are, on average, the more of your time you may have been depressed. And so if you're 18, you've been depressed for a year now, you have 1 year history of depression. If you're 65, maybe you've experienced 10, 20, maybe even more years of your life depressed. And what we're learning more and more is that there are effects of being depressed on the brain chronically. And the longer that people have been depressed in their life, the more difficult to treat it is. As far as your question about differences between males and females, we're starting to look more and more about that. Historically, we've done a terrible job about that, both in clinical research and in basic science research. Most of our animal studies are done in male rats, and we completely ignore the female ones because they have complicated things like, menses cycles and so forth, and researchers didn't want to deal with that. But fortunately, that's changing. So a lot of our drug discovery work was done exclusively in male animals. And in our research studies, fortunately, women are well representative because women are more likely to suffer from depression. But there haven't been nearly as much work done trying to dissect out the differences between response between men and women. We know generally both respond to treatment, but there may be differences in which treatments are best for them. We particularly have developed more and more interest in how sex hormones may play a role in the treatment of depression. 2 years ago, we actually had the first ever treatment approved for postpartum depression, which was not another oral antidepressant. It was a neurosteroid very closely related to some of the female sex hormones. So it was the first ever treatment approved just in women, specifically for postpartum women, and was a very unique medication in that it's a sex hormone, not just a chemical.
Awesome. Thank you, Dr. Sis. It looks like we have a question from, sorry, I'm toggling through the chat, from Marion Stewart Thomas related to TMS. Marion, do you want to unmute?
Yeah, hi. Thank you for your talk, by the way. And my question was, other anxiety disorders, are they also treated with TMS or no?
Yeah, thank you for the question, Marion, and thanks for being here tonight. Right now, we have good evidence that one anxiety disorder could be treated with TMS, and that's obsessive compulsive disorder. It's FDA approved. Like I said before, it's not really covered by most insurance yet. They tend to lag behind the research quite a bit. And that's one that I feel confident that some patients will really benefit from. Other anxiety disorders like generalized anxiety disorder, some people consider PTSD a flavor of anxiety disorder, or social anxiety disorder. The research is very limited, but the potential is there. The way that TMS works and the way that we think these disorders work is something that TMS could be helpful for. What's particularly interesting about when it's used for OCD, it's actually not just stimulating the brain. They pair it with what's called exposure therapy. And the idea behind exposure therapy is that normally something is frightening, but if we desensitize ourselves to that thing over time, gradually, we learn that this thing should no longer be frightening. And so anything that provokes anxiety or is frightening could potentially be desensitized with exposure therapy. The cool thing about TMS is that it enhances learning in the brain. And so something that might work okay with exposure therapy or might take a long time with exposure therapy, we may be able to really facilitate that learning faster by pairing it with TMS. And in fact, that's what we're doing with our methamphetamine use disorder study with TMS. We're actually going to give patients cues that they might come across that would encourage them normally to use either cocaine or meth. They're going to resist because they're going to be in our clinic and we're not going to let them use. And then they're going to get the TMS immediately following it. Yeah.
Okay, we've got time for maybe one more question, but just as a reminder, we have about a minute left, so it'll have to be quick. Adrian, you've asked a few questions. If you want to pick one question to ask real quick, that would be great. Let's see. If not, I can go ahead and pick one of them.
I think I just was able to unmute my microphone.
Go ahead.
I'm sorry I was late and I missed a lot of the beginning, but I'm just curious to find out if you still, or if the treatment of the use of clonidine TTS1 for anxiety disorders to prevent the anxiety to escalate to panic by use of decreasing cortisol is still considered an appropriate treatment for anxiety.
So real briefly, we do use clonazepam or Klonopin and other benzodiazepines for the treatment of anxiety disorders. Its practice about how we use it has changed over time. We really like to reserve those for really extreme situations because people do develop dependence on benzodiazepines over time, but they can be incredibly valuable medications for some people with anxiety.
No, maybe I didn't make myself clear. I meant the patch, not the oral medication. There's a TTS1 patch that's used.
Clonidine, yeah. So clonidine patches are also used for some people with anxiety. They kind of block our natural adrenaline surge that some people get with anxiety.
Are there any updated studies, any newer studies other than the ones that were done after the Vietnam War, where people were coming with severe shock syndrome or PTSD, as it's called now?
Yeah, there's been a lot of really exciting research in PTSD recently. I think there's kind of two flavors to that: is how do we prevent it immediately after something traumatically happening, or what do we do when patients are experiencing PTSD symptoms? How do we treat that better? And again, one of the exciting things that's recently come about is the use of psychedelics in this realm. And there was a really exciting study looking at MDMA for PTSD that came out just a few months ago.
Awesome. Thank you, Adrian, for your questions. And thank you, Dr. Sis, for answering all kinds of different questions tonight. We appreciate your time and we enjoyed your presentation. I'll let Jenny close us out from here.
Thank you as well. I join Mindy and Charlondra in thanking you, Dr. Sis, and to everyone for joining us. We appreciate you being here and for your really smart questions. We hope you enjoyed this evening. We wanted to let you know we have our next episode is going to be Wednesday evening versus Thursday. It'll be June 9th, and it's going to be about COVID research with UT Southwestern doctors Trish Pearl, James DeLemos, and Sandeep Das. And we're going to share about the 249 plus research projects underway on campus, hear about the unique National American Heart Association Registry of Cardiology data that we started, and then also just hear reflections from Dr. Pearl on this pandemic. She's been observing infectious diseases around the world for 35 years, so we hope you will join us. And just one more comment about COVID. Our parting message tonight is to please get the vaccine. For vaccine appointment information, medical blogs, and FAQs about the virus and vaccine shots, we encourage you to visit our website at utswmed.org/COVID-19 and just peruse the site. We have so much information on there. And for now, we wish you good health, good spirits, and a good rest of your evening. We are adjourned. Thank you.
Thank you all for coming. I appreciate it.